Hello and welcome to the webinar. I'm Cassidy Ovula with the Center for Optimizing Rural Health. Today we are pleased to present how to win the tyranny of small numbers, collaborations, coalitions, and networks. Before I introduce our speaker, I will let you know that you're muted at this time, but if you have a question, we invite you to type it into the chat box and we will anonymously address those at the end of the presentation. So now I would like to welcome Shannon Calhoun, our speaker today, and I'm going to start by reading her bio for you. Shannon is a distinguished healthcare executive with 24 years of experience in the industry. She is a leader of collaboration and collaboratives that develop strong relationships and build consensus throughout multiple organizations. Shannon specializes in network and business development with record success in creating economy of scale and scope while protecting financial autonomy for participating providers. She has spent the last 5 years in network and business development in value-based healthcare transformation and alternative payment models with an emphasis on practice transformation and collaborative accountable care organizations. While serving as Vice President of Network Development for a grantee under the Transforming Clinical Practices Initiative, a Centers for Medicare and Medicaid Innovation, program, she gained knowledge and experience in assisting clinical practices, rural health clinics, and FQHCs in readying for participation in value-based payment models. She also served as VP for a national leader in the transformation and implementation of innovative healthcare models for supporting quality, cost effectiveness, and health promotion for the improvement of the well-being of rural and community health systems. For more than 20 years, Shannon led the development of virtual integration, where hospital members utilize network business lines to access enterprise solutions while maintaining financial autonomy. Her work includes the development of rural PPO network, provider-payer contracting and credentialing, fee strategy development, direct contracting with employers, a development of a strategy for CHIP and Medicaid. Much of Shannon's work focuses on programs that better position providers for healthcare payment and delivery reform, and her goal is to create sustainable solutions for both the network and the network's healthcare members. So Shannon, at this time, I will turn it over to you. Welcome and thank you so much for being with us.
The three of us because with now BPHR and forward, trying to convert that over.
Good morning, Cassidy. Can you hear me?
I can.
Okay, and then you're gonna have to admit people pretty much the entire time.
Shannon, I can hear you. Are you there?
Yeah.
Okay, 1 second, everyone, and we will figure this out and get started shortly.
But I did make it to my hair appointment. I'm back from my hair appointment.
Shannon, can you hear us now? Okay.
She's in the participants list. Does it show her as muted in there?
It does not. Okay, I apologize, everyone. We are working on Shannon's audio, and if you'll just give us a few seconds, hopefully we'll be able to get started.
Cassidy, can you hear me?
Yes, I can hear you.
Okay, if it's possible, I'm having a hard time hearing you.
Okay, let's see. Give me a second.
Maybe I would call in and I can use my phone as a connection, and that would be better.
Okay, you want to try that?
Yes.
Okay.
1 second.
Welcome to Zoom.
There you go.
Enter your ID followed by pound.
Okay, Shannon, do we have you on the line?
Probably her. Whatever that is.
Star six.
Cass, can you unmute me?
Mute one named Shannon, but mute that from the, because that's where the cross.
Oh, there she is. It's so hard to.
Another number just came in.
Oh, unmute Shannon or mute Shannon?
Mute Shannon.
She's muted.
Unmute the number that just came in.
Okay, let's see what number that
It was
was.
like 1217.
1217.
If you had to, just unmute all the phones and see.
Shannon, can you hear us?
I sure can. Can you hear me?
I can.
That's my echo. Just a minute. I'll turn that speaker off.
Okay, one of our in-house.
Here we go.
Oh, great. I think we can hear you pretty well now.
Excellent. I apologize. That might be on my end from having some storms roll through last night in my rural community. So I apologize.
No apology necessary. We're just so glad to have you on the call with us today. So I have given an excellent introduction for you. So if you want to get started, then we are ready.
I'm happy to get started. Thank you so much for that, and welcome everyone. I am thrilled to be here to talk to you today, and I'm very happy to be part of the journey that you are on in this transformation time of healthcare. If you would change the slide, Cassidy. Sorry, I lost connection. There we go. So first of all, thank you so much for the Center for Optimizing Rural Health and Texas A&M for doing this big project and helping all of you, and also HRSA for the work that they do. Today, my interest is really to help each of you understand what's happening with payer communities in regard to their view and negotiation with rural providers. The specific objective, of course, is really to identify the barriers and the opportunities for the current-based climate that we have in healthcare today. I also would like to, sorry, my connection is just going off and on. I'm going to move to my own slide deck, and Cassidy will confirm that we're on the same slide deck.
Okay.
We can figure this out. So the second objective, of course, is to really talk about how to connect with one another and to be able to really leverage the opportunity, because I do believe there's great opportunity for rural healthcare today. So with that, I'm going to make up a little bit of time, and if you can move to slide 4. I want to do a level set for all of us, talking about where we are in regard to healthcare transformation and the changing healthcare market. So it's interesting that we are in such a state of change. And I want to make sure that all of you understand, for a long time when we started in this transformation, certainly there was a belief and a hope that rurals would be carved out and maybe even have some exceptions to that. And so I want to do a quick level set And so slide 5, please. Obviously, Medicare is the largest payer in the country, and in the mid-teens, so 2013, 2014, they started an initiative that we've all been subject to, obviously. This is a slide from the Learning in Action Network. It's probably around 2014. And that blue arrow on the left-hand side really talks about the intentions and the foundations of which everything that you can see in place today that's actually still standing. So the first one is provider accountability and innovation. And what you're going to see in almost every payment model and every program, it's going to have a component that is trying to make sure that there is a way in which providers can innovate. In other words, they're going to try to remove some barriers for you. And this is in general, not necessarily speaking to rural, but they want you to also be accountable. And being accountable isn't necessarily a negative. It means that you are given the opportunity to have information to know how you have more control over the outcomes of your patients. The second one is the impact of payments on cost and quality. So they want to know and track that any provider that they use, Medicare or the government, any provider that is a delivery of the services they have for their beneficiaries, they want to know that there is a proof of cost and quality. There's an accountability of the value and of the overall spend. Then they want to see that the delivery system is integrated in some way. In other words, it's not just working in silos anymore. The information that the physician has is connected with the specialist and connected with the ancillary work and also with hospitals. And they want that to be patient-centric, not provider siloed. So it's really interesting to see that this is exactly what we see in an ACO or in the direct contracting from the Primary Care Plus initiative. The other thing that's really important about this slide deck is the left bubble graph is really the state of affairs at the time that the slide was developed, and the right bubble graph is the trajectory of where they see it going. And what we all need to note is in category 1, it's fee-for-service, which is traditional Medicare payments. And at that time, the majority of contracts or payments were with fee-for-service, and there was no link to cost or quality. Category 2 is probably like readmission rates, bundle payments, the beginnings of those. And then category 3 moved over into actual types of payment methodologies, new payment methodologies, but with a toe still on that fee-for-service structure that we're used to. And then finally, category 4 is sort of global payments, like what we're seeing coming out of the Pennsylvania Rural Health Model. You can see in the trajectory on the right-hand side that fee-for-service is not intended to stay around. Counter to that, what I also see in that graph is that some bit of a comfort in that they want it to work, and they're not expecting everybody to be in category 4. There's opportunity to be successful, but I know in certain terms, the 4 tenets of the blue arrow and being able to participate in cost and quality is really here to stay. So if we can go to slide 6. And slide 6 is really about my perspective of where I see Medicare overall. And this is a summary. We've talked a lot about transformation over the last several years, so I don't want to be redundant. But we know that the beginning of the initiatives of transformation, Medicare had an intention to bend the cost curve. And what that really means is that they had the biggest entrance of a cohort in its history, which was the baby boomer addition. And with the baby boomer addition, it escalated the concerns of the delivery model and the payment model that was not considered sustainable. And so they have this intention that they want to bend the cost curve. That's to create that payer sustainability, to keep Medicare around. And to do that goal, they are seeking to change the system. And what a lot of people thought was that, we're talking about changing the payment model. But I can tell you, I think that it includes changing the delivery model. There is quite a bit of intention of not the status quo of the delivery model. And in doing that, at some point, there is ultimate risk in engaging in transformation. Now, we can talk about financial risk, and you can call it upside risk and downside risk. And from a rural perspective, all of us believe that we have risk every day in survivability in small numbers, not to speak to any of your guys' quality, but when things change and you have small numbers, it's pretty difficult to manage the chain because you don't have enough margins to do so. The point is, there's a new kind of risk. They have everyone to have some expectation of managing or engaging in some type of risk. And I don't see that going away. What I'd also tell you, I worked for 5 years in the ACO, collaborative ACOs, recruiting rural participants into collaborative ACOs across the country. And what we knew with the data set is that everything that comes out as an opportunity is weighted to people already engaged in transformation. That means participating in the merit-based incentive payment system. That means participating in other alternative payment models. And what happens if you're not is that the weights of the measures for payments going forward, existing payments going forward, if you are not participating, you are significantly disadvantaged in participating. So, it would be another presentation, but my recommendation would be that even if you're exempt, you start paying attention to what they're asking for in the merit-based incentive payment system, and consider what your data says and whether or not you can participate in it. And then finally, to sort of seal the deal, one of the things that they put out as a trajectory was that they froze the Medicare fee schedule. I don't know if any of you remember, but they called it the doc fix in legislature, or the SGR, Sustainable Growth Rate. And that was basically Congress ignoring increases to the basic fee-for-service Medicare fee schedule for physicians for almost 16 years because no one knew really what to do about it. So politically, they thought it was too hot to make any changes. 2015, they froze it at the state that it's in, and from that, they basically gave a couple of percentages, like 0.5% over the next 2 or 3 years after 2015, to say that that would help in engaging in transformation. What it doesn't do for you, of course, is if you're an encounter reimbursement, it's not touching your fee schedule. But any physician that's under the Medicare fee schedule, you're affected by that. By and large, 80% of the country is under this rule of frozen fee schedule. And after 2019, there's no increases to the fee schedule, none. And not even are there included the inflation rates. So over time, you're losing 2% a year in aggregate, so 10% by 2026 that you would be losing just by not participating in value-based payments. So it's here to stay. It's really important. Now, counter to that, last March at the National Rural Health Association conference and this is the next slide, please, slide 7. The NRHA conference in Atlanta, Seema Verma from CMS came and really spoke directly to rural health and said, we haven't forgotten about you. We really want to work with you. And her offerings were wonderful. They, of course, during the quality payment program, which is the implementation of the merit-based incentive payment program, they actually provide support for small, underserved, and rural practices and helping them participate. So they're giving you support and being able to participate in the programs. They also felt that being able to connect with specialties and with patients, that they wanted to include new telehealth payment policies as well as the broadband capabilities. So that's been in play almost a year now. Also at that conference, she announced the Medicare Wage Index, which is a long-standing problem and really a great announcement that hopefully all of you have benefited from. And then last, her offer was that she would be expanding value-based payment arrangements that cater to the unique needs of rural communities. That was in the section of the primary care initiatives that was called Primary Care First and Direct Contracting. Interesting models, a great opportunity for entities that are very specifically focused on primary care. What's to note, though, and if you'll move on to the next slide, there are some things that were not offered or stated. This is on slide 8. And what's not included in her offer was removing the value imperative. In other words, Medicare's not moving off in any negotiation of what they consider important to every one of their beneficiaries when they're acting on their behalf. In other words, if they're buying healthcare through their payer initiative, they want to know that every provider serving them is accountable to the quality. And they have a certain definition on quality, and we'll get to that in a bit. And then the total cost. Now, cost doesn't mean what they're charging you or what you're getting paid, but cost means what's the total patient spend on average and in a year. And that really changes the landscape of concern for rural providers, and we'll try to touch on that again in a minute. So that sort of wraps up the leader of payer initiatives in the country. Other payers are following suit. They're not going to be as comprehensive. They're certainly a lot more proprietary, but Medicare is trying to pull them into that realm, and the commercial payers have the same problem. So if we can move to slide 9, and this is going to have a couple of slides really talking about the healthcare market. So again, this is building on some of the problems and barriers that you as rural providers would have. And the first one is changing the payment methodologies. In 2010, almost 90% was fee-for-service, with very, very little on full population care across the country. And this isn't unique just to rurals, but across the country. And in 2020, we've evolved to more in population care than we do in fee-for-service across the country. And it's pretty equally divided, that we have different payment methodologies equally in 1, 2, 3, 4, 5 different ways. So this is a difficult thing for rural providers to weave through. We need consistency and stability on the payment methodologies in order to manage under low numbers, low volume. If we can move to the next slide. Now this is actually the government and commercial payers, and sort of a demonstration of the measurement across the country of the movement on that bubble graph from the left in category 1 on fee-for-service all the way to population and global payments in category 4. This particular slide also comes from the Learning and Action Network, and it covers 2015 in the bar that are green, and 2016 in blue, and 2017 in orange. And what you can see in each one of those categories is that it decreases in category 1 over time. It's increasing in category 2 and consistently increasing in categories 3 and 4. So this covered not only Medicare and Medicaid, but it covered 61 health plans in the last year, 3 states, and Medicare fee-for-service over 226 million people. 77% of the country is moving in this direction. So the movement is there, and we can't miss the opportunities that it brings. We need to engage in that. So if you'll move to slide 11, please. The other thing that's really creating a lot of strife is that we have 2 polarized ends of the type of patients that we treat. This influences the framework of how we have to deliver and maybe even negotiate payments. And that is, of course, we have the baby boomers entering the retirement age, which creates a need for a lot of management of chronic disease, a lot of time in management of chronic disease. We used to call this an 80-20, where 20% of the population took up 80% of the cost. It's now to what is called the 5-50 population. 5% of the population takes up 50% of the cost. And we need to figure out how in practices can we manage with time the people who are sicker than those healthy that we need to be able to be doing prevention and wellness work with. So the counter to then this baby boomer is the younger or tech savvy people that are seeking healthcare through technology. They want convenient access. They want real-time care, and they also want to engage a lot in wellness. This is, again, polar opposites in delivery, and again creates a fracture in a consistent delivery model that we are generally used to. So if you can move on to slide 12, and this is sort of stating the obvious, but it is not considered sustainable on a fee-for-service model. Payers won't be able to deliver plans. It's created opportunity for a lot of diversity that hasn't been necessarily a great outcome for rural providers. And what I would say in this state of healthcare is that the opposite is that there is opportunity for change. You know, if we have to change, we certainly want to change when there is great opportunity to do well. And I believe that that is the case for rural healthcare. It just requires that we need to aggregate in some way. And before I get to that, I'd really like to talk with you about the actual biggest barrier for rural health. And if you can move to slide 13, this is the moving to the tyranny of small numbers. There is a barrier, and it is because we are small in numbers. And that means statistically and in empirical data and algorithms where they need mass amounts of data to do predictability, we look small. If you'll change to the next slide, please. So let me just talk for a minute about the definition of the tyranny of small numbers. And I'll give an example. Some of you who know me have probably heard me say this, but it rings true and creates a great story for an example of what the problem is with small numbers. I've grown up in rural America. I live in Texas. I grew up in Texas for the better part of my life. I've lived here, and I still live in a very small rural town. And I was third in my graduating class, and that's a great thing, right? Texas has a rule that if you're in the top 10% of your school, that you have the opportunity to go to one of Texas public universities. A slot is set aside for you to apply and be accepted there if you meet the requirements. But they hold that for the top 10%. I was third in my class, and I wasn't in the top 10%. And in fact, I was third in my class, and I wasn't in the top 25%. So the note there is that there was 8 in my graduating class. And, you know, the benefit to that was every one of us went to college. Every one of us really excelled. But we were in a small rural country school, and that large sweeping change created an unintended consequence that didn't help people that are in a space of small numbers. That's really where we are today. The interesting thing is that rural anything, it's not just rural healthcare. We can see it in rural schools. We can see it in, you know, roads and bridges. We can see it in our businesses, in our town squares. It's very hard to maintain a business when you have low volume. And the unique thing about rural healthcare is that we have payment models today, PPS, critical access hospital, sole provider, and rural health clinics, all have very specific payment methodologies based on being ruled by the tyranny of small numbers. It was a great opportunity to be able to fix that problem by creating those models. But what happens in today's world is that the tyranny of small numbers creates an unintended consequence in statistics. And I'm going to talk just a bit about statistics, but the short end of it is that rural providers are really considered outliers. So if we can go to that next slide. I spent years negotiating payer contracts and at a network level, really trying to figure out how to engage with commercial payers. And in fact, in the last couple of years, I actually called a friend who's a CEO of a Medicare Advantage plan, and I said, you know, I really want to create a specialty network that's built on the terms that rural healthcare are, and then that will solve the problem so you can have access and sell your plans in rural communities. This is a really nice person, and she wasn't being rude, but she said, why should I do that? Why would I want to do that? And I said, well, you know, all healthcare is rural. We need to provide healthcare in the rural communities. And she said, if they're not of high quality, I'm not going to have a plan and deliver it there. And if it's, you know, if they're not reporting, it doesn't show high quality. So my next best step is to get them transportation to a high quality provider, a documented high quality provider. That's real. It's out there. It's happening. Medicare made a change this year that Medicare Advantage plans can use transportation as a way to move people to get to those places that are measured in cost and quality. So what we need to know under the definition of statistics is that if there is an outlier, that outlier can cause problems in their algorithms to determine what the payment for premiums are going to be, what their medical budget might be. They actually consider outliers as a problem. So if we'll move to the next slide, I'll actually explain that a little more. So they can be really important and they can be unimportant. And if they carry little weight, if they capture inaccurate information, then they are considered unimportant. If they carry weight, if they are offering data that you don't see, even if you in the larger cohort of data, then they become really important. And I would challenge all of us collectively that we should be falling into the second category when in fact we're being put in the first category. And part of that is because we are not contributing to the data story. And I will talk about that in a minute. But I actually called a friend, and we can move to the next slide. I called a friend who works in bundle payments, a company that's just doing nothing but analysis for bundle payments across the country. And I said, do you guys have outliers and how do you handle them? And she said, oh yeah, we do Winsorizing. And I said, it's a thing? Winsorizing is actually determining that they take a percentage off the top of the data set and the bottom of the data set. And there's some methods to making that what that percentage is, but basically they take 5%, that takes 5% off the top and 5% off the bottom to normalize the data. And in fact, when I was looking this information up, they don't just trim it out, they actually censor it. So it's not considered at all. If we're falling into the unimportant, then we're not considered. So let's move on to the next slide and I'll explain a little bit more. If we're talking about those states of affairs that I just talked about in the market share, and there's a lot of strife in the payer community. The payer community is working on statistics and artificial intelligence. They are working on determining what their risks are going to be. And in doing that, they will exclude outliers. That is a method of risk analysis. So, and moving on to the next slide, we can see that there are data-driven external pressures. They have competition of other payers. We have a need for perceived relevance. There is a demand for quality. We need to give a supply for quality. We need to give a demand for value. And they don't know it except in our claims data. The way you're measured is in your claims data. And what's happening is as we are documenting based on our tyranny of small numbers designations, then we are not compelled to do that. If we go back to that market share slide and look at 2010, we really didn't need to because 90% of our business was Medicare and the governmental payers, and they weren't requesting that. Everybody in the market share, Medicare, Medicaid, self-pay, no pay, commercial payers, everybody is demanding for quality and value, and we have to engage in that in order to get past perceived relevance and actually be relevant and really important. So let's move to the next slide. Let me give another example. And Dr. Dickey will remember this, I think. But in Texas, Blue Cross Blue Shield created a thing called the Blue Ribbon Network. And this is about 5 or 6 years ago. And what they did was created a Blue Q scorecard. And the scorecard was done on 427 hospitals in Texas. And what they did was gather publicly available data. And the data they looked at was things that were on your website, like participation in Six Sigma and Leapfrog and other reporting that maybe rural providers don't report in because we're small and low numbers and the meanings aren't appropriate. They are not significant, or they create outliers. For instance, if you're supposed to be reporting on the presentation of myocardial infarctions in an ER that how many of them received an aspirin within 15 minutes. If you only have 3, or you have 3 with exceptional variation, it's really hard to demonstrate high quality with a question of how many and no other question behind that. So the result of this exercise was that they ranked people as exceeds, meets, does not meet, not enough data, or declined. And they identified and created networks in their system that showed who was blue ribbon, who was light blue ribbon, and who was clear ribbon. Probably, I don't know, 75 or 80%, maybe 90% of rural providers did not have enough data to even be considered significant in any of the ribbons. And the reason why this is really a scary thing is because they didn't even come to anyone as a provider and say, this is how it's going to be, and you have a chance to you know, participate in it. They went straight to the patients of their plans and said, guess what? You don't have to buy a new plan, but if you pick one of these providers in this network, you're going to have a change in your copay and deductible, you know, progressively between the clear and the dark blue network. Basically, that incentivized patients to choose providers that were in the network instead of close to home for no reason but affordability. That's really, really happening. I mean, that's a 6-year-old story. And I can't imagine how we could find the other stories that are happening around us. So to summarize all this, if you want to move to slide 21, we're thinking from a payer perspective. We have to manage medical budgets and manage risk, and that requires analysis. Risk analysis requires statistics, and statistics, there are outliers. And if they are unimportant, then we Windsorize them. If they are really important, then we sort of consider them. But we are rural providers by default and definition really become outliers that are unimportant. If we are not reporting data, then we're not bringing something meaningful to the table. And so the question is, you know, okay, what do we do about that? And I threw this slide in because I think it's really important to think about it. If you can go to slide 22. So slide 22 is the effective status quo. And the truth is, if we're the only provider in town and the majority of our payer mix is the government, we've not had to really market with competition to an urban town or a neighboring town. We generally had one payer, and our documentation was actually driven by government programs. So the truth is that if we stay status quo, and if the payers do not adjust their analysis for the tyranny of small numbers, we will be left behind by default. And probably some of you can see that in your numbers. So on to 23, please. So what value do rural providers offer to CMS and other payers? And value really equals, this is a general comment, but it's pretty true across all payers. Value equals outcomes and patient experience divided by cost. Now, outcomes sometimes have been judged as, you know, I can't control my patient. What they're talking about is outcomes of your effort. In other words, are you asking about smoking cessation? Are you doing annual wellness visits that also measure A1Cs or BMIs? Are you reporting those as an initiative that is actually identifying the risk and then actually creating a way in which to take care of those patients? Rather than being on the transaction, are you able to do proactive outreach to patients rather than reactive transactional care? That's really what they're talking about in outcomes and patient experience. The total cost on average in the country is anywhere from $7,000 annually to almost $13,000 annually. And when they're talking about cost of care, they're talking about, can you do something like a biologic infusion therapy for a person that had diabetes and is a candidate for amputation, or in the hospital first and then amputation, so 2 or 3 episodes? Can you, in fact, provide a service of secondary prevention that would keep that cost from happening to the patient? And you know, in that scenario, that's a great thing for patients and for providers, because if we can be innovative and implement something like that, then we have a great opportunity to actually be beneficial to the population and engage in transformation and get paid for it. So that's what we have to do in this value game. And then the next slide, 24, is really about your value story. When you're marketing, you really need to talk about the value in terms of what the payer's asking, because that's what your competition is in the world. They're putting it out as, honestly, people don't come buy from you directly. Generally speaking, they're buying their plan and doing what their plan says. And so we need to demonstrate in the plan's words a way in which the plan wants to say, this is a coveted health system. We want you to go there. And I believe that we can do that. So let's talk about how we can make that happen. If we can go on to slide 25. How do we solve problems? The problems are the new payment models based on value with operating under low patient volume and low data volume. How do we actually do that? And move to the next slide, 26. However we do it, we have to become statistically important. And the first thing we have to do is tell stories through our data. So this would be yet another conversation and a good hour-long one, but tell stories through our data. Those offerings that the work that you have to do under the quality payment program or the merit-based incentive payment program, and probably the program that you're in now with the center, is that you're documenting. Those of you may know of the hierarchical condition category coding. That talks about the severity of the disease state. And payers will understand that if your patient is high cost, it's because they have a certain severity of the disease state, like retinopathy and neuropathy for a diabetic. And then I would say collectively across state or region, nationally, we should all be, as a rural group, agreeing on the platform of which we tell our story. Because if we want to be statistically important, collectively, one rural voice is 60 million people. That's the people that live in rural America. And so how we need to tell our story, and we have no leverage, no negotiation with the payer without having our story consistent across a large cohort. And you can go to the next slide. It's my new chant, one rural voice, 60 million people. How come 60 million people are an outlier? I mean, I don't think that should happen, and I think that we as rural providers have a great opportunity to have a rural voice. We just need to be speaking in the purchaser's terms. And so that's what I mean by one rural voice. We need to speak in a voice collectively about how we're different, but how we're very valuable. And so my answer to you, and moving on to slide 28, is that we have to aggregate. So what's the opportunity in aggregating? And that is, if you come together collectively in a network, you have the opportunity of creating an economy of scale and scope to act as an enterprise while having independent, autonomous financial control. Now, I've done this. I've actually managed a network for 25 years and ran it kind of like a co-op. And we negotiated payer contracts. It stands today. I'm not working there anymore because I moved on to the ACO side. But it actually stands for about 25 payer contracts with 13 hospitals participating in it and physicians. The leverage of working collectively gives you enough data to be significant. Now, what I did learn in the last 5 years in the ACO is to actually negotiate with a payer on a payment methodology, you need to have 50,000 lives. And in some states, that's the whole state, and it might be even more than the whole state. Some of the recruiting that I did in the collaborative ACO side, those of you in Mississippi have a great rural voice. There's probably about 65,000 in an ACO. If there's any in Oklahoma, you're moving to a point of a rural network there that's about 75,000. And you see that in Michigan and Wisconsin and perhaps Indiana. Hopefully that's happening in Pennsylvania. So there's an opportunity if you collaborate, and you don't have to be, managed by another system. You don't have to give up your own financial autonomy, but you work collectively on that value story and have that value story documented in your data so that you have leverage. And that gets you to a point of payer negotiation. You also have the opportunity in doing that and legal structures to do some shared services. Perhaps care coordination is a hard thing for some of you to do by yourself, and maybe your neighbor has some really great care coordination plans. Shared services go all the way back to shared laundry and all kinds of other interesting things that neighbors can do, even if they're competitors. And then obviously the volume for evidence. We need evidence to tell our story that we are of high quality. We just measure it differently. So if you'll move to the next slide, 21, and I'm going to keep moving because I do want to leave about 10 minutes or so to answer questions. There was a book called The Managed Care Handbook by Peter Kongsfeld that wrote in 1995, and why I read it, I don't know, but I did. And I loved the virtual integration definition. It's all components of a segment of healthcare system act in concert for a common cause, but none is an employee or a subdivision of the other. And that's the type of integration that I'm talking about. So let's explore a couple of those opportunities and collaborations, coalitions, and networks. And what I would tell you, if we can move all the way to slide 31, Cassidy, thank you. Coalitions are really temporary. It gives a point to figure out who you want to work with and perhaps what you can do on a initial step. It doesn't have to be very formal, and it doesn't even have to be everybody in 100% agreement on everything. But coalitions give an opportunity to understand that perhaps you might be competitors, but you can be really great neighbors and figure out how to create some of that volume that we talked about. And then collaborations, if you can go to slide 32, collaborations tend to become almost a little more formal. Doesn't necessarily have to be a tax ID number, but certainly it is perhaps a legal agreement of some sort, how everyone comes together and everyone wins in the same thing. So it's more inward facing, where coalitions might be a little more outward facing. But this creates a peer community in a way in which that you can actually create some great leverage. Then moving on to slide 33 is the network. And the network is much like what I described under the virtually integrated delivery system. You can have all types of partners. They can be hospitals and clinics and DME and home health and even payers or businesses. Depends on what your intention is to build that network. But you have the opportunity with a goal to actually become more competitive and have an opportunity for innovation. And so, you can start on the path, and each one are progressing from coalitions to collaborations and then to network. What's really the fashion of the day is clinically integrated networks. So I want to spend a couple of minutes on the clinically integrated networks, and that is starting with slide 34. Clinically integrated networks also have a commonality of those coalitions, collaborations, and networks, and that is that they're trying to improve patient care. This definition also included that Medicare AAA, better health, better care, lower cost. So when they're clinically integrated, that also goes towards the FTC or Federal Trade Commission legal requirements of competition. So clinical integration has been around for a while, hasn't been really successful because there was a lot of barriers. The beautiful thing about an ACO, which it could be considered a clinically integrated network, but an ACO is a payment methodology. So if you form a network to join an ACO, then you'd probably be considered a clinically integrated network. And being in an ACO actually gives you legal protections for Stark and antitrust, if done correctly by the Medicare shared savings model. So there are similarities to things that we're comfortable with. Primary care medical homes really focus on primary care services. IPAs or independent physician associations, a lot of us have seen where those independent physician practices that may be in mid-sized towns and cities maybe don't have an anchor of a hospital for infrastructure, so they work collectively in the IPA. And then sometimes there are PHOs, the physician hospital associations or organizations, where you see IPAs or groups of independent physicians and hospitals come collectively together. Now, we've seen changes in all of these in IPAs and PHOs because of the marketplace, the strife in marketplace. So I've seen a lot of mergers and acquisitions, a lot of purchasing of clinics. All of those are ways in response to market share. The important thing about rural providers, specifically nonprofit and mission-driven to the taxpayer, or just mission-driven to their community, is that they want to remain autonomous and independent. So having virtually integrated, clinically integrated networks gives them the opportunity to be in one of those with leverage. So the components of a clinically integrated network really are these 7 categories. There are legal options in the structure, and it would depend on your state. It would depend on what your intention is and what you're trying to achieve, but you would want to have a legal entity for a clinically integrated network. You would need physician leadership because it does require, under clinical integration, that there be some physician participation in the engagement, in the change, and in the process methodology that's consistent across everyone that's in the program. You'd want to have participation criteria, and I think the reason for that is that, in my eyes, it provides a heck of a lot of opportunity for participants to have a clear understanding of what everyone's requirement is to participate. It really keeps the competition down. It makes it very clear of who's seeing whose data and whether it's important or not. It sort of lessens the competitive concerns once you have really strong participation criteria. And then, of course, you do have performance improvement activities that's consistent across all of the participants. You would want ultimately to move to information technology. You don't have to build it in-house. There's lots of ways. There's lots of outsourced opportunities in that regard. But you would want to be able to do some predictive analytics or work with a company that would do predictive analytics. And this would give you the opportunity to have great leverage in your contracting options. Having the ability to have your single voice to negotiate. One of the things that I was able to be successful in, we had outside of Houston, a rural network of 6 hospitals under a contract, and no question, all the commercials wanted us to only use Quest labs and not our own in-house labs. Obviously, our own in-house labs are not just reference labs, but a little more expensive, and the cost was more expensive, and so they just wanted everybody to wait, even if they were in surgery and ER, to wait for the $8 lab transaction. And we fought hard to actually be able to make the point that if we don't have our own labs doing all of our labs instead of outsourcing them to somewhere else, we won't be able to provide the extent of services that we do. But one contract is like, okay, well, we're just not going to have that community in our provider list. But having 8 in a region that refers to urban made a significant difference in that conversation. So you have good opportunities in that. And then if you're when you move into like an ACO, the dollars may actually flow directly to the tax ID number of the clinically integrated network. And when that happens, everybody needs to know very clearly how the sharing of funds, how the movement of funds would go. Again, that brings a lot of competition way down and collaboration way up. So those are all important components of a clinically integrated network. And if we can go to a couple of more slides. The other thing I just want to say is that clinical integration does not mean that you have to be one single system under one tax ID number. It does not mean that you have to have a closed system of information. And in this day and time, it's becoming easier and easier to do that virtual integration. It does mean that you have to have processes across the care continuum. And that's a new way of referring to people, building narrow networks and being able to manage what other people are doing based on your intentions is a little hard to do and not necessarily in all our wheelhouse. The good news is everybody is moving in this direction, so even your referral entities would want to participate in some form or fashion. So finally, a couple of quick reminders and consideration of the clinically integrated network is that they may, depending on the work that you do, could be regulated by the Federal Trade Commission, so you want to be very, very sure that you have good legal. It is a legal structure. The CIN is a legal structure. An ACO is a payment methodology. So keep that in mind. And then is a clinically integrated network a payment model? Not necessarily, no. It really is a structure, an organization of rural providers. And that was slide 37. I didn't tell you, I got all excited, sorry, Cassidy. So I'll end with my one little pitch, and that is one rural voice, 60 million people. I really want to see the opportunity of the great benefit of what rural healthcare delivers to the people that live in rural America. And we have to come together as a single voice, ultimately, over time, consistently sharing our story and become significantly statistically relevant. So with that, I'll close, and Cassidy, you can put out questions.